so that's basically it. So we've done stable Turkey, we've done unstable Turkey, we've done unstable Brady. So we'll just do a full mega code as how it will happen in your exams. Okay? Right. Okay. Would you like? I will need someone to stand here and take over the floor. I'll just off this.
Abang Edwin.
Yeah. Oh dear, battery low. Touch again. Okay. Charging now. Right. Okay. So, you want to stand there? I don't know. You can actually replace. No, you stand there.
Oh, really?
Just asking about your other friend.
Oh, okay.
Alright. Okay, so we just do a typical one. An 80-year-old lady comes into you with complaints of tired lah, doctor. Hen lei.
Hi, madam.
Yeah, doctor.
What's your name, madam?
Ho.
Oh, Madam Ho, I'm Dr. Edwin. Okay, how are you, doctor? How are you feeling?
I don't feel good, doctor. That's why I'm here.
Okay. Do you have any chest pain?
Don't know lah. Don't
Okay.
feel good only.
Right. Do you have any shortness of breath?
Got.
Got lah. Okay. Can I get a team? Okay. Can you give me the defibrillation machine and the cardiac monitoring and the research trolley? Okay. Right. So, Madam Ho, I need to check your. I'm going to open up your shirt. I'm going to check your chest a bit. Now it's okay with you.
Yeah.
The cardiac monitoring.
Okay.
Okay. Find the cardiac data. Okay.
Just cakap je whatever you're doing. So.
Okay. Right, I'm going to check for the pulse. Okay. Is pulse
Feeble,
good?
small
Feeble,
volume.
perfusion, CRT.
Very cold. CRT is 4 seconds.
4 seconds. I'm going to ask her to the lungs.
Clear.
Clear lah. Okay. So can Azrin, can you help me take the blood pressure?
Okay, measuring blood pressure.
Okay.
Mina, you want to ask Madam Ho anything else?
Do you?
So you've asked. Okay, sorry, I am blue. Okay, yeah. So blood pressure is blood pressure is 80/40. SpO2 is 90%.
90%. Okay. So patient is having some hypoxia. Actually, can you help me just give some face mask?
Okay.
Okay, so analyzing the rhythm, this is like so it's tachycardia narrow complex. It's irregular as well, and I'm unable to see the P wave, so it's atrial fibrillation.
Okay, alright.
So it's a fast atrial fibrillation.
Complete diagnosis?
Unstable fast atrial fibrillation.
Okay, alright.
Okay, so Madam Ho, it seems that your heart is beating very fast. So because your condition is not really stable, we'll give you some specialized energy, which will develop some specialized energy to your heart, so that it fix it to try to stop the heart from beating very fast lah. Okay. Don't worry, it will be painful, but don't worry, we give you some painkillers as a sedative lah. Okay. So Azrin, can you help me set a large proranula and take the cardiac enzymes, electrolytes, and also blood gases. Julie, can you help me prepare midazolam and fentanyl? Midazolam 2 mg and fentanyl 50 mic, and give it to the patient. Okay. Do you have any before this? Do you have any allergies?
No, doctor. No.
Okay.
Okay. Midazolam given.
Okay.
Fentanyl given.
Right. So I'm going to synchronize cardio with this patient. Okay. So setting to synchronized mode, 120 joules. That's the lowest it. Okay. Right, so gel, pad, on. For this one, and the patient's TCS. Okay, Madam Ho. Gel. That's okay. So below the clavicle and below the apex. Right. Oxygen off. Charging. Okay, so 1, clear, 2, 3.
I'm going to charge on 3.
Oh, I'm going to charge. 3, 2, 1.
Put up water later.
Okay. So you clear, I clear, everyone clear. Okay. Rhythm is still atrial fibrillation, short delivery. Okay. So first one, the oxygen bag. Reassess the patient's condition. Madam Ho.
Not responding.
Madam Ho.
Not
Okay.
responding.
Check the pulse. Any pulse?
No pulse.
No pulse. Okay. Can you start the chest compression? I will change to backlog mask. Okay. So actually stop compression first. Analyzing the rhythm. It's pulses ventricular fibrillation. So continuous chest compression. I'm going to start defibrillation. So defib at 200 joules, no synchronous mode. Okay. Gel on. Okay. Right. Charging. Okay, stop compression, hands off, oxygen off. You clear, I clear, everyone clear. Okay, still in ventricular fibrillation. Strong deliver, continue chest compression, and then continue the left off mask. Okay, so John, please help me deliver a good quality, high quality CPR. So make sure it's hard, 5 to 6 depth of compression, and then
What
fast,
depth? 5 to 6 what?
5 to 6 cm
Okay.
depth. Okay, and fast, 100 to 120 compression per minute, and then minimize interruptions, and then allow full recoil, and switch every 2 minutes. Okay, or if you are tired. Okay, so I will this watch excessive ventilation. So give every 2 breaths to every 30 compressions, and 1/3 of the depth of 1/3 of the gap ambu bag. Alright. So Azrin, can you help me prepare 1 milligram of adrenaline, IV adrenaline, and don't serve it yet?
Okay, 2 minutes.
Okay, 2 minutes up. Okay, stop compression, hands off. Analyzing rhythm. Any pulse? Sorry, it's still ventricular fibrillation. Continuous chest compression. I'm going to defib the patient. So 200 joules gel. Continue compressions. Okay, charging. Okay, stop compressions, hands off. You clear, I clear, oxygen off as well. Everyone clear, still ventricular fibrillation. Delivering shock. Continue compressions. Continue back off mask. Okay. Azrin, can you help me serve the one IV adrenaline now, and then serve it every 3 to 5 minutes, and then also prepare your my amiodarone 300 mg. Don't serve it yet first, yeah.
Alright.
Okay. How's the switch compress? How's the compression ready? Okay, yeah. How's the ventilation, Abis? Is it tight?
Not so good. Yeah, like.
Not so good. Okay. Do you want to check the mask? Is it mask correct? Is it properly fit? Okay.
Everything correct.
How about this?
Still not good.
Okay. Are you confident with putting an LMA?
Suction first, boss.
Or suction? Yeah. I'm gonna check suction first.
You don't kacau, you just check. Tolong ada
Any
people here.
secretions? Shut.
Okay. Yeah. He don't want to follow your order. He wants to intubate. So terus intubate.
Session.
Intubate.
Intubate.
Intubate. Okay. So since you intubated already. Okay. So.
Okay, so once you intubate, what are you supposed to do?
Okay, so check for the correct placement of the
So how do you check that?
So direct
So then
visual,
you continue to
the gold standard would be direct visualization.
Yeah, he has visualized it. And you want to control me as the team leader?
As a team leader, also PTCO2. Okay.
Before that, so you
Capnography.
actually check here.
Check for the 5. Auscultate the 5 areas.
Okay,
So
where are the 5 areas?
the epigastric region, the stomach, and then the left quadrant, left lower quadrant, right lower quadrant, and left upper
Both
quadrant.
pieces. Okay, good. The first point is going to be your stomach first, okay? Because if it's in the tummy, you immediately take it out. Alright. So after that, you attach to anterior CO2. What kind of reading do you want to do?
Okay, I want to make sure it's adequate compression, so ET CO2 at least more than 10 millimeter
Okay,
mercury.
so if for example the ET CO2 is 5, what do you do?
Ensure the compression is good.
Okay, so you just tell him, can you please make it
Yeah,
better?
or switch
Or
compressors.
switch. Okay, alright, good. So 2 minutes is up.
Okay, 2 minutes up, stop compression. Analyzing rhythm. It's still in VF. Continue compression. I'm gonna what do you call that? Defeat the patient. Okay, gel. 200 joules. Okay, stop compressions. Okay, you clear, I clear, everyone clear. Okay, delivering shock. continue compression.
Okay.
Okay. Okay. Azrin, can you help me serve the 300 milligram amiodarone now? And then continue prepare amiodarone 150 milligram and also begin. Okay. Then
Third cycle CPR, what are you gonna do?
the cycle of CPR. The cycle. Let's check the.
Bloods.
Then after the
Check the
bloods,
bloods, okay?
5
So what,
Ps.
yeah, what bloods are you interested in at this point?
Blood gases.
Okay, which part of the blood gases?
pH.
pH, okay. So pH is 7.
7, so acidemia. Bicarb.
7.
Bicarb 7 as well. So it's metabolic acidosis. Okay, so Julie, can you help me prepare? Can you help me serve IV sodium bicarb 50 mils, 1 ampule step.
Is 50 mils
One.
going to be enough?
1 times.
Okay, so it's
100.
usually 1 mil per kilo. Okay, so for a 70 kilo guy, maybe you
70.
give 100 mils instead. Okay, what else do you want to do?
Check. Look for the other plus potassium.
Potassium 7.
Potassium also hyperkalemia. Okay. So Julie, can you help me serve calcium gluconate 10 mils, 10% 10 mils over step, and as well serve IV insulin 10 units and also 50 units of 50 mils of dextrose 50%.
Okay, alright, given.
Okay. Right. Okay.
2 minutes up.
Okay. Stop compression. Analyzing rhythm. Okay. Pulse present. Pulse present. Okay. Okay. So
You can feel
silence
the
rhythm.
pulse.
Okay.
Really?
So return of spontaneous RSE lah. Okay. So stop the compression. I'll proceed with our post RSE care.
Okay, alright.
Okay.
So I'll stop you at that.
Okay.
Okay, thank you. Okay, so for ROSC, what you want to do is you will go through the ABC again. Okay, so just go through back from A. So just check again that chest expansion is equal, and this is a good time for you to re-auscultate the patient's chest. Okay, and then going into breathing. So this is a good time for you to attach the patient onto the ventilator. Circulation wise, just check the patient's blood pressure again. If it's low, what do you do?
Start heavy iron.
You can actually give some boluses of fluids kilo at a cost of 100 to 200 mils. Failing which, if blood pressure is still low, then you can start the patient on some vasopressors. Usually the vasopressor of choice is going to be your noradrenaline. Okay, alright, and then subsequently you can go ahead to D. So D, what do you do in ROSC?
Stability, flow or temperature.
You actually check and coordinate the patient. Okay, you say Mr. Ahmad, Mr. Ahmad. Okay, so there can be two outcomes. One is Mr. Ahmad actually opening up his eyes. The other one is Mr. Ahmad tak respond also. If for example Mr. Ahmad can open up his eyes, you're supposed to give 1 step command. Okay, just 1 step. So say, Mr. Ahmad, can you lift up your right hand, for example. Don't say, can you lift up your right hand and correct your video, for example. Oh, yeah, banyak sangat, it's too many things. You just give 1 step command. If Mr. Ahmad is able to obey 1 step command, you just sedate him and that's it. But if Mr. Ahmad cannot obey 1 step command, or if Mr. Ahmad didn't even open up his eyes, then you can consider targeted temperature management. Okay, there's a different chapter. There's a whole chapter by itself. I won't touch it, but that's when you actually consider targeted temperature management. Basically, if it's unresponsive totally or unable to obey 1 step command, we will consider doing targeted temperature management. Alright, so that's for D. And after that, obviously, you're going to dispose the patient off. So this is a good time for you to order your investigations. What are your investigations you want to do?
Update ECGs.
Okay, and your chest X-ray. Why do you need a chest X-ray?
To confirm the placement of
For
the
placement? Is it for placement?
and also to look for other
It's for the
your
depth.
fight of
It's for the depth of the EDT, not the placement. The placement was confirmed by direct visualization,
And auscultation.
by the auscultation and by the capnography. Okay, but not by doing a chest X-ray. Okay. Okay, so you're doing your child PBCG. Okay, so you check. So if for example there is ST elevation in leads, so 1 AVL V5 V6. What's that?
anterior anterolateral
Lateral.
MMI
A lateral myocardial infarction, and the plan is going to be your
PCI.
PCI. So I'll just say that I'll call the cardiologist to arrange for a PCI. Okay. So apa ni, and then don't forget your RAS tube and also your CBD. Okay. One drug that you need to give.
Pantoprazole for stress ulcer prophylaxis.
Okay. And that right. Katalah there's no problems with the ECG. ECG is sinus rhythm saja. What are you going to do with the patient?
Look for other cause.
Look for just now based on the underlying causes,
Mhm.
and then refer to the respective team and call ICU for admission.
Good. Okay. That's where we wrap up our mega code. Okay. Any questions whatsoever?
We need to explain for the ROIC, the post-arrest care as well.
Depends on where the examiner stops you. Okay, so sometimes it depends also on the timing, how complex the scenario was. So some scenarios will deem to be a bit more complex, where you RIC they don't expect much of a discussion. If the scenario is a lot more simpler, then probably you go all the way up to RIC. But you should be able to comfortably talk about everything. But RIC is basically just going through ABC. I know that in your ACLS guide there is like other things which is being jumbled up, but I feel that the ABCD approach is a lot easier to remember. And it's something which we are very, very familiar with. Okay? Any other questions?
Just now the nuclear angle, because we are so used to the nuclear angle everywhere.
I don't know why you're so used to it, because you're very young, aren't you? The decision to actually start with I'm going to shop on 3, 1, 2, 3 was a decision made in 2015. Which year are we in now? We are due for the next ACLS punya guide, and you still want to hold on to the old one, which is rather interesting. Okay, so you're wasting time. 1, I'm clear. 2, you're clear. 3, everyone clear. Oxygen off. Still in BF. Shock delivered. 12 seconds. Okay, I'm going to shop on 3, 1, 2, 3. Shop.
I'm going to shop on 3, 1, 2, 3.
Yeah.
Okay.
But you have to, like I said, show what you mean.
Yeah.
So when you actually hold on to the pedals earlier on, you must show that I'm going to shot on 3, 1, 2, 3. Okay?
Provided the team must also understand what we are instructing.
Which part is not clear? I'm going to shot on 3. You don't understand what is I'm going to shot on 3? One more thing is, don't say I'm going to shot on 3 and then suddenly you say 3, 2, 1. What do you mean by that? That means that you don't understand English. I'm going to shot on 3 means that you're going to shot on 3. When you say 3, you will shot. If you say I'm going to shot on 3, 3. What on earth is this person doing? Betul tak? If you want to do a countdown, say I'm going to shot on 1.
3 to 1.
Yeah. Okay.
Understood.
So be clear about your orders. I'm going to shot on 3. Which part of I'm going to shot on 3 do you not understand? 1, 2, 3, 3. Okay, 3 means please. But having said that, if you have problematic people, I'm going to shot on 3, 1, 2. Because you know 2 is clearing you. Tapi you still kat situ juga. 2. Then you ask them to go away lah. Okay? There's no point in saying, 1 I'm clear to you, okay, everyone clear, or say off. Pun tak guna juga, betul tak? Are you clearing people? You're not clearing people. So the main thing is, show what you mean. And say what you mean. Then only you're safe. So whatever it is, the main thing is safety. So as long as you can ensure safety, in the meantime also not cause too much of a delay, you're actually winning it. Okay? Alright. Any other questions otherwise?
I think probably another thing to improve is when 2 minutes up, we said hands off, checking hands off, and then switch compressor so that we don't forget to switch the compressor.
That's why also again to just make sure that that thing is out of your mind.
Yeah.
Terus you cakap masih bagi you punya first order.
Yeah.
Yang high quality speed tu, push hard, push fast, 100 beats per minute to emergency, allow full surgical, minimize interruptions. 30 to 2, okay, you will bag 400 mils every time, and every 2 minutes you can stop. Easy for you to tell them. Siap-siap, so that you already know, you already tell them. It was blinking just now, Min.
Ya, tahu. Bila stop.
And then,
So habis
Tapi
dah
benda tu still recording.
Okay.
then I think one more is after the intubation, actually the compression and the intubation has been separate, like respectively.
After the yes, of course. Yeah.
Yeah.
So that's the other thing. So you are supposed to. That's not because I cut short the 2 minutes. Tapi technically speaking, when you already established the capnography is at katalah 12. Contohnya, like you can now you can continuously just compress at 100 beats per minute, and you continuously at
Every 5 or 6 seconds.
One breath.
One breath
One
every
breath.
6 seconds.
Okay, so that's how you do.
One more question is the flatline protocol. Do we still perform it?
Of course you do,
Yeah.
okay. Tapi you have to be very careful with what you do with flatline protocol. So we'll just take that out. Okay. So say for example, it's now flatline. So you are supposed to hands off. I want to analyze the rhythm, and you check, and there's nothing there. So you just continue chest compressions dahulu. So while she does it, I'm now doing my flatline protocol. So flatline protocol there are 3 stuff, right? What are those?
Check the lead placement.
Check the lead placement. So this is while chest compression is going on. So you continue, okay, betul-betul everything is on, everything is connected nicely, my machine is on, there's no problem with power at all. I will increase my size, so I just have a look at here, it's times 1.5, I will increase it up to 3. So that's maximum for this machine. If I'm not sure that I can just pusing balik and it's going to start balik, so I just go back to 3 just now. Okay? And then while I'm confirmed everything is there, then again hands off balik. Hands off now. So I just really confirm for a few seconds. Tak ada juga. Okay. And then you continue. Okay?
So one is the lead placement, one is the amplitude.
And then
the one
really
is
checking the
to
pulse.
check out.
But you only, after you have ensured all the other things, then only you check the pulse.
Okay.
Don't off dulu and then while tengah hands off, you cari ni, how many seconds are you wasting? Don't allow that. So while you're checking for the machine and the lead size, you continue chest compressions. But the last part where you actually have to check the pulse, that's when you hands off for a while just to check the pulse. Okay? Anything else? Tak ada. I hope that was clear enough. I managed to clear any doubts for you. Okay, alright, thank you.
Thank you so much,
Thank
Dr.
you,
Tan.
Doctor.
Good.
Was any
Targeted.
new to you? No. Tak.
Because I was asked by Dr. Kiran the target temperature management. So 34 to 36, right? What kind of solution they use? What kind of method they use to keep the temperature low?
You can do anything as long as you can keep the temperature low. So you can go to the extremes of even doing lavage to keep it low. The first things first is usually we just take off everything, take off all the baju. Apa ni, give a bit of fan there. To be honest, in our research hall, there's no problem because our external temperature is always very cold. Just make sure that you don't overcover, don't put a warmer, for example, on the patient. So you just remove everything. Next step is obviously starting to put ice packs on the patient. Subsequently, it's by if using cold saline. The last very bad, maksudnya, despite we've done all that, and then still the what do you call that? The temperature is still high, 38, for example. We can actually do cold lavage.
How cool is the saline should be?
It's actually from fridge cold, so it's 4 degrees.
4 degrees.
Yeah.
And she actually asked me, what medication would you give?
What medication we give for?
For targeted temperature
For
management.
shivering?
For targeted temperature management.
To be honest, I don't think there's any specific medication. We can check the articles. As you can see that we don't really do it lah. Because most of the time we are able to achieve the temperatures anyway once we actually allow the patients to be in our hospital. You generally can achieve 30, 36 definitely. If you're around 36.2 kind of thing, we're going to leave it as that. We're not going to sangat nak bring it all the way down to 35.8 just to appease to some people. It's actually very difficult, and as you are able to appreciate, probably it's going to cause a bit of problems, especially in terms of acidosis. So it's going to cause a bit of acidosis. So you have to balance in between that. So if acidosis is an issue, you may want to settle the acidosis part because that's going to kill the patient immediately. Okay? Alright.
Usually they won't come out stable AF.
Stable AF?
Because the
But then
movement
they'll
is
be
different. That
different.
one is
What do you mean by they?
Yeah, I mean like ACLS. Because stable AF is not part of like that. You give like the rate control usually.
Yeah.
So it's usually not part of ACLS. So usually.
Well, the thing about stable AF is that there's no real hard and fast rule to it. There are a lot of things to manage. In fact, AF by itself is quite a difficult rhythm to see as a whole. As you can appreciate, maybe with our master students who we're still kind of like having problems with trying to identify a particular method in managing atrial fibrillation as a whole. Some are very pro beta blockers, some are pro digoxin, some are pro calcium channel blockers. So it's very difficult to really have a particular method to it. To be honest, for someone relatively junior like you guys, I would definitely not pose a question like that lah. But I can't really speak on behalf of the supervisors. But bear in mind, those are the methods lah, technically speaking. You have your beta blockers, you have your calcium channel blockers, you have your digoxin, KIV, amiodarone if you are interested in that. But you have to know when certain things are contraindicated. For example, beta blockers are contraindicated in asthma, calcium channel blockers. Sorry, besides the asthma, what else are contraindicated for beta blockers? Yeah, and
Tyrosine. Sorry,
it's a
sorry.
medical.
That's not.
If it's APO,
APO.
or overt congestive cardiac failure at that time, you don't want to, especially if the cardiac failure is due to the current situation itself. Okay, so you don't want to use beta blockers. Calcium channel blocker, the main problem is if you can do an echo and see the ejection fraction, then that's good. If you can't, then you can't give it. Because it's going to cause your blood pressure to crash. Okay? Then that's why you see most of our patients got digoxin lah.
Oh. But that one also need to be cautious. Elderly
Yes,
people
definitely. And
all.
especially the potassium has to be in a good range. So you want the potassium to be not less than 4 for you to actually give digoxin. If it's less than that, then you may get digoxin toxicity instead. Okay? Or not effective digoxin. Alright.
Thank you, doctor.
Thank you,
Thank
doctor.
you, doctor. Thank you so much.
Thank you guys. Sorry, Mia.
Okay. Sorry, it's okay.
How long was that?
It was an hour.
Ah, okay.
Ten
Not that